Selamat sore, very good day to all of you. It is a pleasure to be back with Iges after so many years away. I think the last time I was with you was in Malaysia. Our topic is laparoscopic suturing. I think you have gone through quite a lot of it. So by rights, I'm sorry, the lecture is supposed to be at the beginning where we're talking about the basics. So I am actually taking you back to the basics of laparoscopy and what is the challenge of laparoscopic suturing. We all know that it is basically operating and suturing and shifting is a totally different type of change. And many of our seniors during my time when we were doing laparoscopy just could not make the change. But then all of you are in the video games, all of you play video games, so you have absolutely no problem looking up at the screen and doing what you need to do and getting the feel. So this is a totally different generation, and adapting to laparoscopy is not a problem. But laparoscopy suturing is a slight different, because we have been taught all along laparoscopy, trying to do everything with bipolar, with diatomy, with clips, and whatever. And these are all substitutes for suturing. Because suturing is, I think, the thing that prevented people from doing good laparoscopy. And all this is, you can see with the fulcrum effect. The pivots where you actually have only stuck to one point and have to move around that. That makes it very difficult. And not tying, I think it is a skill that not many, because of the fine point. With laparoscopy, you're doing 2D. So now you have to actually get the parallax to get to the effect of doing all the knot tying. So that's where the problem is. Many of you are like me. We live our whole life with what we call lazy eye syndrome. So when I was young, one eye was short-sighted, and so you actually play, like when we play badminton, it was very bad because all the time it's a wood shot, you always miss the sweet spot. But for laparoscopy, you are able to compensate. And so the lazy eye syndrome actually became an advantage in laparoscopic surgery. Now, the conclusion basically is laparoscopy is a very high level skill, and it takes a lot of training and practice before you are actually good at it. And all these constraints make it difficult for you to do. So, extracorporeal, the two main laparoscopic approaches are extracorporeal suturing, which has its advantage, and intracorporeal suturing. So you can do the knot tying. It is the most difficult part that is actually the gold standard. So we'll talk about extracorporeal suturing. I mean, here you just get a pre-tied loop and then push it to the side, and it's quite good. It's very good for pedicles and when you do the forming. So in fact, when I was teaching the surgeons to do laparoscopic cholecystectomy, this was the method we chose because it was so simple to do the tying. And Kirsten himself used the Rogers knot, where you do a complex knot and slip it down, and you actually it's very good. And it's also come as what we call angle loop, where it's a complete nowadays maybe if you do proper suturing, you don't need it. But these are what we call the crutches that we started off using. And you can see that third Sam using his left hand the rhodes, the endo loop. But he uses a simple straight needle at the end of it. It just brings it up, makes the rhodes knot, and then brings the plastic and pushes the knot in. That was how he did his initial suturing. So he started off because it was easier doing extra suturing. So here it is showing the bone leather, as I said, that we call our surgeon friends. This was the easiest way to do it. But of course, they went on to using clips, actinic clips, which of course made it much simpler instead of having to do lining. So these are just the steps of suturing. I wouldn't really go through because these are best learned during the actual hands-on. Talking about it doesn't make much sense. But you can see that you place the loop, tighten it, push the knot in, and then once it's secure, that's it. So the other way of doing that was introduced was by Clark. They call it a Clark bridge because every bridge popularized what Clark used to do. And this was a simple thing from a bicycle scope which he used to tie knots. And that actually made one very well. Now, the pros and cons of extracorporeal suturing is very fast, simple ligations, but there's less control. You can't make it as tight. There are ways and means of doing it tighter. You need an assistant to hold the knot and then you tighten it. So that is one way. But generally, it is not as tight as intracorporeal suturing. And that's one of the reasons. Okay, there is also the risk of sawing because you're using a long, you see when you saw that, you're using a long suture. And then when you're pushing it through, sometimes once you're sawing it, and sometimes whatever suture, or let's say it's a blood vessel that you're trying to tie, it ends up sawing it and it breaks, and then you have all the blood all over the place. So that is also, those are some problems that we have. But this is fantastic for the future. So on whole concept, the entire process of intracorporeal this is moving on to intracorporeal suture. Now, the entire process, everything is inside. Suture handling, not tying, everything inside the cavity. And then you need at least 2 needle holders. So these are the gold standard for suturing and doing everything intracorporeal. This is fantastic for anastomosis. If you don't do anastomosis, if you do anastomosis, this is the only way to go. The urologists and colorectal people have found that staple, they get by it with staples, but the urologists, I think, find it not possible to do staples because the ureters is too small. Vaginoplasty and all the others, they all need proper suturing intracorporeal. The needle handling, we always grasp it at a 90-degree angle. So you can see here, it is grasped. And it's usually, many say do it at 1/2 rule, but sometimes when you need strength, then it's easier to hold it at 50%, but always at right angle. You can see that this one is not exactly right angle. So what you have to do, you have to move the point so that this is exactly right angle, otherwise you will slip. Suture management, keep the sutures short when you do this corporeal, otherwise you get tangled, get the dancing of the threads. essentially you see that it is quite comfortable sort of ipsilateral position. So if you're doing intracorporeal suture, there are two ways you can do it. Ipsilateral suturing, that is both parts of the same side. I think for all the ladies, this is the easiest to do. I mean, I can't imagine women operating with a hand stretched over to the other side as contralateral suturing. And this is much more comfortable, but it has its more difficult points. Now, on placement, I think the ipsilateral position is easier for beginners, and you notice that the movements are actually similar to what you do with movements in the before, and definitely much more comfortable. But the limitations is that there is some clash as always, and you have to learn how to triangulate. The contralateral position, I think you can first look at it and see how difficult it is. You're blocking the other person's view with your arm. But Kurt said, for example, no, he did it very well. But I remember going to watch him in Kiel operating, and we could see that his assistants were trying to look over his shoulder, move to the left, move to the right, because he was contralateral and nothing else. You can see that even here, my assistant has to have difficulty moving to one side so that she can see what is happening and hold the camera properly. And you can see that it's not an ideal way of holding the camera. Just stretching out. So that is the ergonomics contralateral suturing. Definitely you'll find it requires a lot of practice to master, more so than for ipsilateral suturing. And that's one of the reasons many people did not go into suturing, and that's used dietary all the way. I would really go through this part of suturing. This is you will go through how to
Ya, maksudnya itu yang tangan
I think what you really need to do is more practice. The main thing about intracorporeal suturing, it has a lot of advantages, but there are also disadvantages. No, the biggest problem is always you make the suture too long. I actually suffer from that because I always try to use one long suture because it's cheaper and then you can use it many times. But it has the risk of being tangled. Now those of you who use the new barb sutures and without that, you'll find that for economy, many of us say we go for the 45 centimeters, but you end up always asking for the short ones, the 15 or the 30, because those are the short ones are easier to handle. So for all things, try to use the short ones to handle. I did not touch on one technique using short needle and tying the knots at the end so that we can save it. But that's the thing we can do during the workshop. Okay, so overall, this is the biggest strong point that superior knot security tighten. But secure, like I said, if you have a good assistant who can hold the knot for you just when you're doing the time, it's just as good as intracorporeal or extracorporeal. Just that intracorporeal will save on this soiling motion which can actually cause tissue destruction. And definitely it is much more precise, but it is very time consuming and it takes much time to learn. think both are useful. In the end, you need to know both. And knowing both, you use advantages of one versus the other. I think the feature of extratemporal, both, it is difficult to learn, but of course the extratemporal is learning faster. So just a little word of wisdom. You start off learning with the extratemporal techniques, meditation. Once you've mastered, then go to the master intratemporal switching for advanced switching. That's really not much of a choice. So just learn the first one, extratemporal first, be good at it, and keep on practicing your intratemporal. Which takes a bit longer for you to learn, but eventually you need more. Just sound surprised by saying that, and by saying laparoscopic surgery is the cornerstone. Whatever we say at the beginning, we say we look for all different things, using the plates, using anatomy, using ultrasound, and whatever to bypass the need for surgery. We realize that it is the cornerstone and it is what makes manipulating this surgery. Those who go to robotic surgery will find that yes, we go back and actually rely so much more on the ease of our surgery that we don't really too much about using all the clips and other ties, plastic ties that we have. So remember, intratemporal surgery is the gold standard of precision and security, and you need to master both the ipsilateral way, which is easy to start off with, and for sometimes when you have no choice, you actually have to do certain sutures using the contralateral method. And the choice of technique depends on the procedure. So these are simple, honestly, common sense. And there's no substitute, absolutely no substitute for consistent practice on your simulators. So whatever you're doing now, later, just in the end, you still have to go back and keep on practicing. And one thing, just remember when you practice, you always operate on the side of the patient. You are not standing in front looking in the camera. That is how a general surgeon stands between the legs and do the policy. For you guys, you always stand on the side of the model, not behind the model. So just practice, remember, just do it that way. Make sure you are on the side of the model and operate as you would in the patient, because you are always operating from their side, not where the general surgeons operate. Thank you.
Okay, thank you, Dr. Yong, for the insightful material and presentation. And now all the participants, any question for this session? Okay, any question?
Pertanyaannya jauh Pak. Di sini.
Ya, apakah ada pertanyaan? Baiklah, baiklah. Jika tidak ada pertanyaan, kita lanjutkan ke sesi berikutnya, yaitu sesi hands-on untuk Dr. Edward.
Ya, sesuai dengan rencana kita ya. Ini saya akan tunjukkan penggolongan grup. Jadi grup A ada di sisi sini. Nanti bisa dilihat nama-nama yang tertera. Ada juga nanti di papan itu ada nama-nama yang tertera. Kemudian nanti khusus untuk di grup A ada 4 tower ya. 2 tower sebelah sini ini adalah tower sendiri-sendiri. Jadi satu sendiri. Yang di sini nanti berdua-berdua. Begitu juga nanti yang di sisi yang lain ada yang isinya tower yang isinya ada daging ayam itu sendiri satu partisipan. Jadi tower yang nggak ada isi daging ayam itu 2 partisipan. Nanti kita akan bunyikan lonceng 15 menit, kemudian berputar. Ini grup B di sisi sana, orang ya, bisa dilihat namanya. Kemudian untuk grup C di sebelah sisi sana, dan sisanya grup D sisi sini. Ya, oke, para dokter sekalian boleh ngambil posisinya, buka